Good morning, everyone. So I'll be giving you some pointers on how to interpret an OCT. An OCT is a non-contact, non-invasive diagnostic modality which has revolutionized retinal disease management, and it gives us high-resolution images of the posterior segment, almost like an optical biopsy. And the OCT layers, they correspond very well to the layered retinal anatomy. The resolution of the OCTs have been increasing over the years, and now we also have 3D rendering. So when you get an OCT printout, there is a quantitative analysis here where you get the central macular thickness and also the thickness parameters of the perifoveal areas. And the qualitative analysis wherein you study the different retinal layers. Now these layers are better delineated in the black and white scans and not in the colored printout. So always make sure that you have the black and white printout or the black and white OCT on your screen, which highlights the layers much better. So these are the different retinal layers. The layers which are of concern to us are the retinal pigment epithelium here and the ellipsoid zone here. So the ellipsoid zone has been variously called different names. It was earlier called the IS-OS junction, then it was called the photoreceptor integrity line, and most recently it is called the ellipsoid zone. So there are a lot of new terminologies that keep coming in. There's the interdigitation zone, there is the myoid zone, but generally these are the two things that would be of concern to us. Now, break it down to the basics. So you see the inner retina, this is the inner retina, and this is the outer retina. The part facing inside is the inner retina. The outer retina is the area which is generally affected by choroidal vascular diseases, and the inner retina is the area affected by retinal vascular diseases. Many times when we see the OCT, it's not that we have to look at it layer by layer. Sometimes pattern recognition just helps us to diagnose the condition. So here you see this interretinal fluid which is speckled. Here you see an asymmetric edema. You see that suddenly there is this rise here. Here you see large cystoid spaces, intraretinal spaces. You see some subretinal hyperreflective material here and subretinal fluid here. This is a pigment epithelial detachment with interretinal fluid, subretinal fluid, and hyperreflective material. So just by seeing these patterns, you can diagnose. So this is a normal OCT, this is diabetic macular edema, this is a branch retinal vein occlusion where you see this asymmetric edema. These large cystoid spaces are post-CME, inflammatory CNVM, and wet AMD would present like this, large PED, subretinal fluid. So many times you can just see it and make your diagnosis. So once more, I'll come to the anatomy and explain the layers to you. So if you start from here, this is the choroid. This is the retinal pigment epithelium. This is the ellipsoid zone that I just mentioned, and this is the most important to us, and this would prognosticate the vision of the patient. This is the external limiting membrane. Again, the external limiting membrane goes hand in hand with the ellipsoid zone, and both these have visual, they have implications for the vision of the patient. After that, you have the plexiform layers and the nuclear layers here. And this is the nerve fiber layer here, this one. So like I said, most of the times we'll be looking at the RPE and the ellipsoid zone. This is the ganglion cell layer. So these are the different layers that you should be familiar with. Now, many a times people are not able to diagnose whether this is subretinal fluid or pigment epithelial fluid or a pigment epithelial detachment. So the way to do that is to just follow the retinal pigment epithelium here. So you see the pigment epithelium here is continuous, but here you see the ellipsoid zone, the external limiting membrane are rising up here. So this is a subretinal fluid and not a pigment epithelial detachment. This is a pigment epithelial detachment where you see the RPE itself has risen up and you can see the ellipsoid zone here. So this is a pigment epithelial. This is a combination. You can see a combination. This is the pigment epithelial detachment and this is the subretinal fluid here. This line here under the pigment epithelial detachment is the choroidal layer. So this is how you would diagnose a subretinal or a... So to the audience, is this a subretinal fluid or is it a pigment epithelial detachment? Anyone? Subretinal fluid because the RP is intact over here. This one? This is subretinal because you see RP is intact, and here this is subretinal, and this is some hyperreflective material here under the retina. Now, another thing that you can, an interesting thing that you can make out from the OCT is whether this is the OCT of the left eye or the right eye. So the nerve fiber layer here, this nerve fiber layer is thicker near the optic nerve. So this OCT scan, just by looking at it, even if you don't know which eye, would be of the left eye. Now, once you get an OCT, you first determine the overall scan quality. So the scan quality has to be good for you to analyze all the different layers. Make sure the patient doesn't have a dry eye. Sometimes if the patient has a cataract, you can do it from the periphery, the scan, if the if a central cataract is there. Make sure that the lens of your OCT is clean. You can clean it before you take a scan. Reading an OCT is like reading an ultrasound, where superficial structures will affect the underlying tissue. They cast a shadow. So here you see this structure in the vitreous is casting a shadow here. These are small vessels near the disc, so you will often see such shadows on your OCT, and these are nothing but vessels which cast a shadow. So this is again shadowing to show you. And here you see where there's an area of atrophy, here you see the choroidal layers are more prominent. Okay? And where there's shadowing, you cannot see the choroidal layers. After that, quickly see, whenever you're seeing an OCT, you quickly see the overall scan profile. How is the retina? Is the retina detached? Is the pigment epithelial detached? Is the retina thick or is it thin? This is all what you see first. So this is a case, I'll just quickly show you a few conditions. So this is a patient of wet AMD. You see the pigment epithelial detachment here. You see some subretinal fluid here. You see these hyperreflective dots, and this is hyperreflective material under the retina. So this hyperreflective material in the initial stages is amorphous. It is, got fuzzy margins, but once you start treating the patient, it becomes more delineated. Its margins become more defined. This is a CSR, a very common condition that you'll often see. So again, pigment epithelial detachment, subretinal fluid. Branch retinal vein occlusion, there you see shadowing of all the layers here because there's hemorrhage here. So all the layers here under this are obscured by the blood or the fluid. So this is shadowing. This is intraretinal fluid here, and there's some amount of subretinal fluid here. This side, like I said, an asymmetric edema. A BRAO, just by looking at this picture, you can say that this is a BRAO because you see this hyporeflective area here. This is very characteristic because of the ischemia in BRAO. It is not present on this side, it's present on this side. Now, thinning would appear like this. This is the normal retina, and this is the area which is thinned out. So you can, and here you see there is a loss of all the anatomy in this case, so that those patients would not have good vision. After that, you evaluate the foveal profile. This is how the normal foveal contour looks like. Now, this is something called, this is the foveal pit, and it can have varying morphologies. It could be a little deeper, it could be a little, less deep, but both these patients would have good vision. Also, there's something called the foveal peak over here. This is a very normal structure. So this is present normally in a lot of cases. After that, see the foveal profile, where the fovea is distorted or not, whether there's a macular hole, any membrane on top of the fovea, and make sure you have a foveal cut. So many times patients who have macular pathologies are not able to fixate on the light of the OCT. So it's a good idea to turn off the room lights, ask them to occlude their good eye, and make sure that you have a cut right through the fovea itself. So in the structural assessment, you look at the posterior vitreous, look at the OCT layer by layer, look at all the layers now. So identify any abnormal structures that you have. You can see the vitreous here on the OCT very clearly, and you can see whether there's any abnormal attachment or an adhesion. So this is a vitreomacular traction. That was a vitreomacular adhesion. A traction would distort the retinal layers. An epiretinal membrane causing a lamellar hole here. Diabetic macular edema can have the spongy pattern, a cystoid pattern, a serous detachment like this. And most important, when you're assessing a patient of diabetic macular edema, see the vitreoretinal interface, whether there's any taut posterior hyaloid and epiretinal membrane over there or not. Now, the ellipsoid zone, as I mentioned, should be continuous throughout, and this has a direct correlation with the visual acuity. Here you see there is disruption of the ellipsoid zone. The external limiting membrane is intact, but the ellipsoid zone is not, and this patient would not have a good visual acuity. Pigment epithelial detachment I've already talked about. So enhanced depth imaging is now available in a lot of OCTs where you can see the choroidal layers more clearly, especially in pachychoroid diseases like CSCR. You see that the choroid is much more thickened. Now for the audience, what is this? This is something causing shadowing behind. Any guesses? So this is a large pre-retinal hemorrhage, and you see this is the shadowing of the layers behind. Pitfalls in the OCT, so you do not compare the thickness from two OCTs. Every OCT has a different cuts, you know, so the spectralis takes the thickness of the macula from the ILM to the posterior edge of RP and the cirrus to the anterior edge, so you cannot compare the thickness between two OCT scans. That is very important. Look at all the images when you see all the cuts, see all the images, do not look at just one scan. So this was my optometrist who came with this. I thought it was a CSR or some a retinal detachment, but the patient actually had a BRVO. So if you've not got the correct cut, you will not be able to interpret. Don't rely only on the thickness scans. Please have a look at all the different scans and they'll give you a lot of information. So in conclusion, OCT is a very important tool which helps us to diagnose, prognosticate, monitor the follow-up. It should be done on all patients, if possible, undergoing cataract surgery. Many times you'll pick up epiretinal membranes or macular holes, lamellar holes, which you could not identify clinically, and also use it as an educative tool for patients to show them these pathologies. Thank you.
Thank you, Dr. Tinku, for a very elaborate and very simplified presentation. Any questions from the audience?
Can thinning in general be a pathology? I mean, will it have a bearing, especially in the fovea region?
Yes. So generally when thinning, when all the...
And why would it happen? I mean, patient does not have any pathology as such.
So there are certain genetic diseases, certain degenerative diseases, some macular dystrophies which would cause this kind of a thinning, drug toxicities which would cause this kind of a thinning. So thinning on OCT would have a bearing on the visual prognosis.
So we move on to our...
Yes.
Yes.
So around 200 microns in the Indian, for the macula. For glaucoma, it would be different, like for maybe 100 microns, 120 microns would be the normal thickness. Yes, superior is thicker, but...
So...
Ma'am, I'm a PG student, so I have a very basic question, ma'am. Ma'am, how do you differentiate, like in OCT you said, how to differentiate by seeing the thickness for which side of the eye that OCT belongs. So if that patient is having thinning in that specific area, then by one cut, how can we differentiate that?
No, that was only for the nerve fiber layer. By looking at the thickness of the nerve fiber layer, you can make out which eye it is. Nasally it is thicker and temporally it is thinner. Just the nerve fiber, the topmost layer, that's it, not all the layers.